Welcome back to the Gillett Health Podcast, where we give you tools to develop a balanced approach for health. I'm Dr. Kyle Gillett. Today we have a repeat guest. Jim Lavalle needs no introduction for those who are familiar with integrative medicine, functional medicine. He's been in the industry for 40 years at this point, and that's going to be one of our first questions. But for those who don't know, he is a clinical pharmacist and also a nutritionist, and a whole bunch of other things. We'll link his websites and links below for those who don't know him yet. But thank you for coming back.
It's great. Super excited to be on the show.
Yeah. Our first question, as we mentioned, is there is now this huge movement to have more natural approach to medicine and be more integrative. There's the Make America Healthy Again movement, which I think is great that people want to diet and exercise and improve their sleep. You've been here a lot longer than we have, actually longer than both of us have been alive.
Wow.
True. Yeah. How do you see this? Is this?
I don't know if that made me feel good, but okay.
Yeah, no, it's fantastic. You have a lot of wisdom, and that you've seen what I think kind of is cycles of ebb and flow, and conventional medicine and integrated medicine pushing and pulling. Sure. What did they used to call this? Has this happened before? What's going on with this movement?
Well, if I go back really far, it's pretty interesting. The College of Pharmacy I went to was University of Cincinnati. John Uri Lloyd was the founder, who was the most famous botanical medicine extractor in the world, and started Lloyd Brothers Specifics botanical extractions or medicines, and then that turned into SmithKline French. But the history that I had was I walked into my pharmacy school the first day, and there was a wall full of botanical medicines and natural therapies that were prescriptive medicines in the 1800s and early 1900s, right?
The apothecary.
The apothecary, that's right. And I had to learn compounding and had to learn organic medicinal chemistry and pharmacognosy. So it was very natural for me to think of plants and other sources of compounds as just another thing that we apply to people. I think that what it was termed when I was starting out, 1983 was kind of the really first introduction. It was holistic was the big term, which I thought was a little soft because, you know, if you weren't into mind body and you weren't going to meditate and maybe you weren't going to take, you know, some chakra classes, if you were talking about botanical medicines and their impact on a receptor, it all kind of got mushed together. And I'm not saying any of that stuff was bad, right? I mean, I think there's value in meditation. I believe that there's energy centers in your body that Chinese medicine has identified for 5,000 plus years. So all that's cool. But I chose to sit in this aspect of everything that happens on receptors. Emotions can affect receptors. Botanicals, toxins, nutrients, drugs. I don't care what it is. When it gets in your body, it affects the receptor. So I look at it all as a natural progression, but you know, we like to put names on things so that we can create separation instead of just saying it's good medicine. Right? Yeah. And that's kind of what my pet peeve always was. But yeah, it was holistic medicine. Then it went to functional was a faction, I would say, of it. And then there's the subfractions that started to gain popularity, like naturopathic medicine came into play, started to get licensing. So it's been quite a journey. I love the term precision health. I mean, I think precision medicine and precision health is kind of where I settle in right now. Obviously, you know, longevity medicine, kind of cool, but precision's kind of the one that, you know, is getting accepted in the literature, right? So I always kind of sit back on the literature.
Yeah, it's interesting, and different people, different words appeal to them. Like holistic, you know, some people would be like, oh, no, I don't want anything to do with holistic.
Yes.
But they don't realize you're talking about, you know, botanicals or supplements that are very science-based. They're binding receptors. They're doing things in the body.
Right.
One of the things we say all the time is that, you know, supplements and medications both have pharmacokinetics, pharmacodynamics. Just because something's a supplement doesn't mean there's no possible side effects from it.
That's just the pharmacokinetics is how the body metabolizes or affects the drug or the compound, the substance. And then pharmacodynamics, for those who don't know, is just how the drug interacts with the body. the way that we like to talk about it is, what's the mechanism of action? What's the receptor, like you were saying?
Right.
This is something you share in common with Andrew Huberman. He loves mechanism of action. And I think that in long-form podcasting, or this science-y or science mafia community, whatever you want to call it, I've heard that called several times.
I like that.
People want to know the science behind it.
Right.
Because it feels like a lot of holistic medicine, you think they don't care about the mechanism of action. They don't understand pharmacology.
Yeah, I think right on. I mean, obviously, I'm passionate. I mean, I taught 18 years at the College of Pharmacy and College of Medicine at University of Cincinnati, and still on faculty at GW, and teach a lot about that mechanism of action and clearance. Right, kinetics is how quickly is it getting out of my body? What is the half-life of that botanical? What is the half-life based on the dosage form or the delivery method? How long is this stuff sticking around? The other thing I would add to it, the texture I would layer into that is, it's one thing to have mechanism of action and discuss mechanism of action. It's another thing is, does it clinically work?
Yeah.
And
what's
the one
the outcome data,
what's the
right?
outcome, man? Because I've seen a lot of patients in my career. I've had clinics where we were doing 300 to 400 people a week, all precision health, right? 3 rooms running full tilt all the time, and it's just chemistry and banging out people to make sure we're creating the right plan and then looking at the outcome. Because in the end, for me, why I got in it, I'm all excited about finding new molecules. Love that. That's a part of who I am. I'm really excited when I get somebody better. That's what's exciting, right? So it's that combination of, where's the mechanism, how's it applied, how do we effectively use that particular tool, and then how great's the outcome? I've seen plenty of herbs everybody writes about, and it's like, oh my gosh, I don't want to pick on one, but ashwagandha.
Yeah.
I haven't seen that great of results with ashwagandha when I give it to people. Maybe I'm just not looking in the right place. I've seen other herbs do more for an equivalent target, right, of what we're trying to do, what we're trying to accomplish with ashwagandha. But that, once again, just my perspective and my, that's going through my lens, right? Mm-hmm. And then now, of course, there's different fractions, and maybe that makes it different.
Yeah, I think that's a great take, and especially looking at, you can look at outcomes all day long in the preclinical studies, and as we were chatting about before we got started, somebody has to do those.
Right.
The one I'll pick on here is the NAD precursors. Right? I'll say they work a lot better for mice as far as running performance than they do for people.
And
for
tumor growth in mice.
Yeah.
They work better for tumor growth in mice as well.
Right.
Yeah.
So to your point, I'm a stickler for outcomes. Like when we chat with reps, they're like, "Oh, but you want the outcomes, James, right?" And I brought your outcomes. Here they know.
Yep.
So we've got them trained. I would say.
Yeah,
that's awesome.
Here's your study, but we have to record that this is worth $45 that we gave it to you. But we love that reps would rather bring us a study and add our name to the paid list. I know you've done a lot of consulting for pharmaceutical companies too,
right?
But it's kind of crazy to me that these studies are behind a paywall, and there's definitely not things like Sci-Hub where you can get it. But anyway, it's interesting that you have to sign your name that you're basically on the payroll of the pharmaceutical company if one of their MSLs or reps wants to give you a full text of their most recent study.
Right.
The class of molecule or medication that I thought of when he mentioned outcomes data or mechanism of action, and this is actually not on our list to talk about, is SSRIs, because they apparently don't work by increasing serotonin.
Right.
But what has your thought been as SSRIs became huge in previous decades and now are kind of falling out of favor? But we do have a lot of clinical data on them.
Well, I mean, you hit on probably, I think, one of the biggest travesties of care over the last 30 years, because when you look at psych data, like any of the psych med data, it's a 50-50 chance, A, if it's going to do anything at all, B, if they can prove how it works. And we got to the point where like, hey, if that SSRI isn't working, let's just add Abilify to it, right? Remember, when you're not getting an effect, just add another drug. And we're not sure how that one works either. Back when benzodiazepines first came out, they didn't even really have identified the benzo A and benzo B receptors. There was no differentiation in the receptors. So a lot of drug therapies, I think people think they're proven as to where they work and how they work before they get on the market. Mm-hmm. And many times there isn't a proven mechanism of action yet, but there's a clinical effect. Mm-hmm. Now, the problem with that is that that's also where side effects then come into play, right? Mm-hmm. So you look at something like a Nexium, not to get off the SSRIs, but it's a great example is Nexium, where we have to wait until it's on the market to figure out that it's thinning bone and causing protein malabsorption and B12 malabsorption and magnesium malabsorption and calcium malabsorption. Yep. And then I think on these SRIs, I think we've got a big problem in that it's just so variable in response. I'm not going to say that, people that get in an acute trauma like a PTSD situation or an acute anxiety event, mm-hmm. that something like a Prozac doesn't have its very short-term benefit. I think for whatever reason, it's working, right? Yeah. But it's the issue of they really haven't proven statistically that they do that much. Mm-hmm. And that's the biggest problem.
Is there things like Nexium that you think should be prescription only? And are there other things like, intravaginal estrogen that you think should be over the counter? What's your list of what should be switched? Testosterone, maybe?
I don't have a list offhand, but I'd say there's a big discussion about that because look at it in other countries.
NSAIDs?
NSAIDs are really tricky because, I wrote a book called The COX-2 Connection a long time ago. And I brought up that, you got about 160,000 bleeds a year occur due to NSAIDs, 32,000 hospitalizations or more. And I think it's one of those, there should be warning labels on them if you're going to buy them over the counter as to how many you're allowed to take a day. Because people buy them over the counter and then they're taking them like crazy. And if they're exercising, they increase, for example, ibuprofen increases your risk of rhabdo if you're training on any kind of endurance event. But what do people do when they're over 40 and they're achy, but they want to run a Spartan race, or I'm going to do my first marathon? They're chugging down stuff like that. And we know there's an incidence of injury there. So if you look at what should be and what shouldn't be, I think testosterone, I still think people need to have some kind of lab value, because I'll give you a good example. Yesterday, I was working with a patient. He had a 310 total testosterone. Bioavailability was like very low. But I asked him, "Hey, how's your sex drive?" "I'm horny all day." I'm fine. I'm very good. And so I think there's that arbitrary thought of on any drug is, treat to the wellness of the person. Mm-hmm. I do see people that take testosterone. If they're left to their own devices, they'll take too much. And I do see problems when people take too much, right? It's that hockey stick issue, right? You get somebody where they get up into the 1500s, 1800s, and it starts becoming a problem.
Should it be controlled?
I think it doesn't have to be the control that it's at right now.
Schedule 3, I think.
I think
maybe
I don't think
not at all.
I don't even think it needs to be scheduled, honestly.
I
don't think it should be scheduled.
Yeah, this comes into perceptions, right? So people, like you said, Aleve, ibuprofen, pick these things over the counter. People are like, I can just go into Walmart and buy it. It's safe. Take as much as I want.
Exactly.
And, there's dosing instructions that are, you get a magnifying glass out to see them, but people don't do that.
Right.
They take more than they should. And same thing with, the PPIs, like you talked about, that whole class. There's tons of people that have micronutrient deficiencies. But then when you move to the pharmaceutical side, things that have to be prescribed, people may have a little more caution around that. And then even more caution when you're looking at something, this is a controlled substance, which goes back to baseball and sports and not really being a dangerous drug. I mean, I'm sure you are well aware of that history.
Yes.
So there's really this perceptions, and I think some of this is starting to shift a little bit, maybe with, making America healthy, some things that are thought of as like more in this regenerative space, and traditional medicine is sort of poo-pooing them.
Right.
Like, actually, let's take a closer look at those things.
No, I couldn't agree more. I mean, I think it's, it's interesting. I do a fair amount of work with athletes, and in some leagues, you're not even allowed to measure a testosterone. And in some leagues, you could be a male playing a very aggressive sport and have a 160 total testosterone, which means more than likely your ability to recover from an injury is going to be very low, and your risk of having an injury is very high. And they won't approve replacing testosterone in someone just to get them to a normal level when they're playing a very demanding physical sport. So then it gets into, okay, then when is normal? And, it's very complicated on the sports side of it.
Yeah.
I think
they could at least let them use nasal gel and troches and maybe lymphatic absorbed.
Yeah, no, I think there's a role for it for the safety of the person, the person that's playing the sport. It improves their safety index by having adequate testosterone. We know testosterone to cortisol ratios are absolutely, published on for increased injury risk. The more your stress hormones are up, the more your sex hormones are inhibited, because you inhibit gonadotropin-releasing hormone when your cortisol's up. When you flatten your cortisol curve, your immune system shifts, and you create a much more dramatic increase in risk, right? Cardiometabolic risk goes up 333%. Neurologic disorders go up. Mood disorders go up.
Do we know if that's a correlation or a direct causation with a cortisol level? For example, if that person took a bunch of DHEA or suppressed their ACTH, which can lead to synthesis and release of both cortisol and DHEA.
Right.
The number would probably change, but I don't know if the injury risk would.
Well, it starts to get a little bit crazy, because as your cortisol's going down, so as your HPA axis continues to get inhibited because you're continually in fight or flight, you're going to continue to push down your cortisol, right? So then when you get into an extended term, right, over time, that ratio actually gets smaller, but the risk gets higher because you're producing less cortisol to be able to have a fight or flight response, and your sex hormones are suppressed. In men, DHEA doesn't have quite a direct effect even to create testosterone, right? You've seen that, right? You give DHEA and they're making DHT and estrogens instead of making straight up testosterone.
It's probably not going to increase your testosterone unless you're on other things.
Acne and oil production
might give you gynecomastia. Some teenagers that take a bunch of DHEA have worse.
Exactly, and then especially when they add SARMs to it, so they really crash their test completely and add the DHEA, which is even better.
Another great example, DHEA over the counter here, and is it illegal in Canada? Is that the classification?
It's prescription in Canada. It's prescription in Canada. Well, I mean, where the value of DHEA is obviously is that as cortisol is going up, DHEA is protecting the hippocampus, right? So you get hippocampal volume protection. So, reducing that risk of short-term memory loss with extended, elevated cortisol. But really, it isn't about just the elevation of the cortisol. It's the flattening of the curve. It's keeping the body in sympathetic tone instead of sympathetic pulse. Right. So when you're extended into sympathetic tone, now all of a sudden, you're starting to create that's a whole different story as it relates to your metabolism. Right. And that's where the whole thing of losing parasympathetic balance, increasing, increasing your heart rate, decreasing your HRV, right? All those things that are kind of wound into all that. So there's a pretty significant direct effect on flattening the cortisol curve. There's been several studies that relate to that. And then, but it's not, once again, it's assuming that, your hormones went down because you're under stress. Well, maybe it's because your gut's permeable because of that cortisol, and you're letting out a lot of lipopolysaccharide, and that's attaching to your Leydig cells of your testicles and telling you not to make tests. That's the gelding theory, right? The gelding theory is, I think some interesting papers coming out on that now.
Yep.
So it's one of those things where until we start looking at people as whole beings biochemically, like what is the totality of the chemistry that's going on in their body? How thorough can we map it out? And then what's the hierarchy of change that we do, right? Like where do you start? Because, we said earlier, I've been in this a long time, and what I've seen is, people come in with a bag of 30 things, or I get some biohacker business executive that's got a lot of money. I'm nothing against the term biohack. It's kind of cool, I guess. But my point being is, He brings me in 4 pages of Excel spreadsheets of all the peptides, all the nutrients, my bioidentical hormones. Here's my regenerative therapies I'm doing. And I look at his numbers and I go, yeah, but you still got a 98 glucose. You're at a 78% risk of being a diabetic in the next decade. So can we focus on something that's going to make a difference?
Yeah. I
Maybe
guess that
stopping
leads-
those GHRPs. Glucose.
Yeah. This leads me to the question of like, we've all seen these patients where they have a list of supplements. They say, okay, that's too many, or medications, that's too many, or they're doing these different biohacks like you mentioned. That's too many. So where is there a number? Are you looking at specific categories? I mean, we all know what is too many, but then what do you think is too many? Just thoughts on that.
Well, the first thing is how sick is the person? Because I may be more aggressive with a pancreatic cancer case than somebody coming in because they want to increase their telomere length, right? So there's a difference in terms of what is the immediacy of what I need to do, as my team when we work on people. What's the immediacy that we need to get to create a result? And typically that's probably going to be more intense of a regimen, but I don't have a number. I mean, I got to be honest. I don't have a hard, fast rule like I never give more than 4 supplements. I never give more than 2 peptides. I never give more than 2 hormones, right? But I'd say what I'm pretty passionate about is really trying to figure out what people need to get their body moving back towards, and I'm a big fan of the term homeostasis versus optimization. I like homeostasis. Get your body back in balance. There's supposed to be this redox balance, right? I'm creating oxidative free radicals, but I'm balancing it out. And so and I think it might be just because of my, my training initially with more German trained docs. It was more of the biological medicine practitioners like Reckwig, in the 50s and 60s, and all the stuff he wrote is what we're all talking about now, and he published these books 30 years ago. So I think I'm not a big fan of people becoming pincushions on peptides. So I can tell you that's one thing I have a big issue with, is if I just get one more of these peptides, it's giving me this signal, I'm going to live 10 more years and I'm going to feel amazing, right? That kind of thing. I'm going to inject them 3 times a day or 4 times a day. I just think, first of all, we're supposed to live to experience joy and love in our life and like be able to do the things that we love to do and not live to make sure I got my Faraday glasses on at the right time and how many, make sure I'm doing these things 5 times a day. And, so I kind of have a little bit different perspective, maybe because of my years of doing this. It's like, look, I want more time. I want to feel great. I mean, I trained hard last night. I feel proud that I could train hard. Night before jumping on a plane, I could get out in my gym. I could get after it. I'm going to be 65 in a couple months, and I'm glad to get in there and get it going.
You're doing great. What percentage of your excellent health would you say is due to diet, exercise, and sleep? And then what due to whatever else is
like
in
the
your
things
rich
I take
peptides?
in versus who I am?
Yeah, like
I'd say 80% is diet, because I've been a proponent of, really we started 1986 was my first publication on modified low carb, low allergen, anti-inflammatory diet. Right? So I've been passionate about finding out the right foods for people to eat, which isn't always the same thing for everyone, for a long time. Right? So diet important. I've been an avid exerciser since the age of 13. I believe in it. What has changed is that with each decade, I changed the load, because what I could do at 20 when I squatted close to 900 pounds is different than what I can do at 65, right? And I don't even want to try to be that 20-year-old. I want to be the healthiest 65-year-old. So the methods change, but the commitment to that part of the lifestyle is still there. So exercise, diet, sleep, all central to what I do. Did a lot of work. Right now I'm super jacked up talking to you guys. My heart rate's at 58. So, I'm feeling like I'm pretty anxious, right? So I work really hard at managing stress. I had to learn that because I was a hot-headed Italian. from a very Italian family. So I had to learn that, right? And then the 20% is, where's my chemistry at and what do I need to take? Peptides, I'm going to be honest with you. I take a few and I do them in cycle. I like basically, what am I working on now? It's not good to push your mitochondria all the time. I'm gonna be a MOTS fan forever. I'm gonna be an SS31 fan forever. I'm gonna push those mitochondria. Because it's interesting, when we were talking to some folks that are doing some mitochondrial testing, that was, it's a finger stick test, but it's validated against UCSD's muscle biopsy, right? So it's really relevant test. And I was asking them, so tell me, what are you finding out? It turns out the people that are pushing themselves the hardest, in that community of what I'd say optimization folks that are push, always pushing the threshold to make your body work more efficient, they have the worst mitochondrial scores. So that's why when I said talk about homeostasis, how do you stay in balance? Enjoy your life. Enjoy the fact that your lifestyle promotes health, right? Because we forget about that, and we have to teach that to people, which is sad. Because we want to make America healthy again. We have to teach them that. How do you embrace and enjoy that being healthy and feeling good and not having joint aches and not being able to get up off the couch and maybe reduce the amount of gas you're putting off to help your family out, right? Yeah. It's like how much farting's going on. But it's all those things. It's a big deal. I think I was fortunate to have great mentors that I stand on their shoulders, and they gave me that insight. For me, that was important.
Over time, how do you balance the, I guess the happiness of things like banning a food dye, but keeping the perspective that people still need to improve their lifestyle? Because I've seen all over social media, some people they say, we finally did it. We finally banned this. So we can rest on our laurels. And maybe they're not actually saying that, because obviously it's a good thing that happened. But how do you find that balance of being happy, but still knowing that there's a lot of work to do?
Yeah. You're hitting on, I think, the pulse of where we're at now, if we're really clearly thinking through. When we say the term make America healthy again, when you have a full thought about that, I think you strike right to the middle of it. Do we need less chemicals in our food? I had a full spectrum disorder clinic in Ohio. We had in our institute, we had a complete neonatal care, preconception, and spectrum disorder clinic. You could talk to any one of those parents and they would tell you the effect of food dyes and phenolic compounds on their children that are in the spectrum, right? So I think there's a need for that, just because why do we get all the chemicals and no other countries get them? Why don't we spread the love? Why don't they take some of them and we all get them, or we shouldn't, none of us should get them. So I think none of us should get them.
Yeah.
At the same time, I am also not in favor of saying you should never eat a piece of birthday cake. Never have nachos. I can have nachos, plant-based cheese, GMO-free corn.
Okay.
Right? No, honestly, it's like we have to be careful, because look at, a real simple one. Go to Sardinia. Do they avoid pasta? They got the most centurions in the world. They don't avoid pasta. They also walk up 19-degree inclines at the age of 85 and carry their own groceries. And they have a network of social network that is embracing people as they're aging, so they're a valuable part of their community, instead of, when you get to my age, you're kind of an afterthought most of the time. I'm going to go out blazing. I'm not going to go out as an afterthought. But I think that thing of balance is difficult, because people have learned culturally what their love foods are.
Yeah.
So like if fried chicken is love food and Twinkies are love food, and you start taking away their love food, that's where you start to see that flux, right? So I think it's a difficult question, man. I don't know how let's just get the big bad things out of the way, right, first, and let's see if people settle when they start feeling better by not having all the chemicalization of their body.
Yeah. You pull all those things off the shelves overnight, you create a black market for Twinkies. That's what's going to happen. But It is interesting. And there are people, I mean, I've seen these articles where people are, they're talking about the food diet, right? That's a big talking point right now.
Sure.
And there's people that are on the side of, why would we ban this? They're like, I think it's Canada, they said they use blueberries for their blue food coloring.
Right.
Natural, I don't know. I assume there's some polyphenols in the dye still that make it into there. But they're like, so why should they?
We wouldn't call it a health food, though. We wouldn't call it a blueberry Twinkie health food, though, right?
No.
Okay.
So why would we get rid of our blue food? And then some people are like, well, banning red dye number 3 is actually bad because those foods might get more expensive. And I'm thinking, well, I can't think of anything healthy that I would go and think this is good for my body that has a significant amount of red dye number 3 in it. So it's just interesting to see all these perspectives because you're going to have people sort of lobbying on both sides of the issue.
What about methylene blue? Are you going to eat anything with methylene blue?
No, put it in all the food. Everything that's blue.
Yeah, that's funny. Just shop at Whole Foods and let them eat cake. If everyone just went to Whole Foods,
because it's natural.
there would be no dyes.
And of course, if it's natural, it's
Yeah,
good
so
for you. That's why you can eat all natural tortilla chips and you won't gain weight.
I just
Bags
mix
at a time.
honey and lard together, and that's a healthy snack.
Yeah. I love coming here and talking with you guys. This is the best.
Yeah.
So should there be, since banning things is not off the table, should we ban some ultra-processed foods, or what, I guess, actionable things could we potentially do? I mean, it is a difficult question that potentially has to do with policy.
Yeah, no, I think there's some nuances that are important. If you're an ApoE34 or an ApoE44 and you have to worry about saturated fat, we have to get that awareness up because you know what we do? We take out the sat fat from animals and then we shove a bunch of coconut oil in it, and people have the same reaction to the coconut oil because it's a sat fat. So they have dyslipidemias and they get chronic metabolic inflammation. So it's that. How do we start if we're going to really get granular on this? Where do you go with that, right? Yes, ultra-processed foods are bad. First of all, I don't think there's a reason. If you think about it, how many people out of every walk of life, say they go abroad, they get lucky enough they go abroad, what's the first thing they come back and say? Let's just say, other than the scenery, what do they usually say? Man, the food was good there. Why was the food so good there? Because it was less processed.
Yep. And they usually say, I ate as much as I possibly could, and I still lost a couple pounds.
Right, because all the inflammatory response is out of it, right? So I think that this is more of one of those things where if we tear the Band-Aid off, it's going to feel pretty good quickly because people will feel better. They'll feel less bloated. They'll have less lymphatic inflammation. Cognitively, you'll be clearer. And I'm not kidding, make the healthy Twinkie. I don't care. Eat a Twinkie, but make it healthier. Get a, it can be it can be done. And, you're talking about changing a whole, culturally, if you want to take this too far, like we talked about before, Demolition Man, the movie Demolition Man, are we going to take birthday cakes away from kids when we've got this whole generation of children? What was their reward? Eating a cookie.
Yeah.
Getting an animal cracker. There's just all this.
It's ingrained.
It really is ingrained. And that's what I concern myself with more is how do we break that cultural ingrainment of what is food, what is reward, right? Which is driven by dopamine deficiency anyway, right? But it's what is that? How do we start to change that message? Because you guys know it. You're in practice. You see it. You want people to eat broccoli and.
Podcasts and books do help. Alcohol is, of course, a substance and a drug that has also been very ingrained in our society, even through Prohibition. And any little podcast and book, even like this, it's a tiny chip that helps break down that cultural ingrainment. Yeah. I have many patients that said the single podcast that Huberman did on alcohol is what pushed them over the edge to not drink as much anymore. And I'm obviously not against, I don't think alcohol should be banned or prohibited.
It is drank too much.
I think it is drank way too much. Right. And certainly podcasts like that can have huge cultural impacts.
Well,
so
Sales are even down. I don't know if it's directly correlated, but it looks
It
like,
was-
well, the recent studies sure,
make it pretty black and
that
white.
was one of the most influential podcasts of the past couple of years, I believe.
yeah.
A lot of people
Look,
have decreased drinking.
I don't want to. First of all, I stayed out of all social media the first 63 years of my life. And you know what made me want to move into social media was with 40 years experience, I wanted to get the message out.
Yep.
Like anything that I've learned, I want to get it out. And I do want to be a part of that change. So I do agree with you. Books, I mean, I've written 26 of them. I got 2 rewrites and 2 new ones coming out this year, right? So, I mean, I'm passionate about that. And I think you're absolutely right that we all have to do our part. Like, I don't care who it is. And, we can be critical sometimes. At least I can. I can be critical because, I'm in the trenches and I've been in it a long time. And you see sometimes people are doing stuff with strictly hype and marketing, but they are creating a door that opens to that person to begin to grasp health. No matter whether you agree with the process or the method, right? We're opening that door. So I agree with you. I think that, we got to keep getting this information out. It's still very shy in the market.
Yeah. A rising tide will, rise all boats. It'll float all boats on it.
Yep.
What I have been concerned about is now that the Make America Healthy Again is seen as being on the right side of politics. And
Right.
People know that we're not particularly political, but obviously we want to make people very healthy.
Sure.
That on one side, the tide perhaps is rising, but on the other side, the tide is decreasing, which is extremely concerning from a health perspective, because you don't want to push away a percentage of a population when it comes to improving their health.
Yeah, and I think that's really appropriate. One of my big concerns is that people think that they're going to solve all their problems by doing, cold plunges and saunas when they still need medical care. They need to get a blood test. They need to get a physical exam. They need a physician to look them over and guide them still. And if you're doing these other things and they're working great, but don't ignore that other side that's still important. And I feel like that negative wave that you're talking about is like, medicine is bad, those bad pharma companies. Well, I got trained as a pharmacist. I'm a clinical pharmacist. 6% of a pharmacist are clinical pharmacists. So I don't think that medicines are bad. I think that when we falsify the results of studies, that's bad. Right.
Yeah.
And I think we need medicine to push forward. I was just at the JP Morgan Summit. All right. So it's all investment groups looking at biotechnology and health technology. And the term came up, polyintelligence. You guys hear polyintelligence?
I've heard of a polymath.
Yeah. So this is really cool because I hadn't heard this term. Polyintelligence is taking advantage of, and this is where, the CEO of First Robotics, looking at that interface between man and machine. The chief medical scientist for Microsoft. I was at this dinner with really amazing, bright people. I think I was probably brought there to maybe serve wine, but I ended up getting to sit at the table, right? These are very bright people.
I'm sure they wanted your input as well.
Well, it was interesting because polyintelligence I thought was fantastic, because where they're at now is everybody's throwing AI around. AI. Well, IBM put $1 billion into Watson and it was a failure in the medical space, right? So polyintelligence is the imagination and active thought process of humans combined with looking at the truth of nature, right? But the how nature functions, combined with the computing power and the ability to rapidly mobilize human intelligence with nature via using this, new, whether we talk about the future and quantum computing, or we're looking at just now with, simple advanced AI, right? When I say simple, but it all starts with, that's where we're at. And I think that's where the excitement's going to get, where it's going to answer a lot of questions for us who are, we're thinking about these bigger issues, but we need to synthesize it all and go, okay, what's the direct path?
So it's like Master Chief from Halo with Cortana on DMT.
Woo, man!
For the natural
that's
implant.
big.
Yeah,
I was just going to
big.
say it's a Neuralink implant. You think you're going to go through a McDonald's drive-through and get something, like 3 Big Macs.
Nope.
But you leave with a salad and a bottle of water. You're like, what just happened there? Your Neuralink takes
Neuralink
over.
with Stargate AI.
And it's like,
Oh,
nope.
man, you guys are totally like I'm still back at Star Trek Episode 1, man. I mean, you got to remember that's the
new
Flash Gordon for me, right?
Have you seen the new AI that the government has, Stargate? They have OpenAI and SoftBank, and they're combining all these things together. I wonder how that will go. I mean, could be good, could be bad.
Well, I think, look, in general, it's interesting because everybody's, asking about AI right now. And, when we developed our cloud-based informatics based on Bayesian modeling, it was interesting because that's why I went to this meeting, was like, hey, have you guys thought about, starting with somewhat of an accurate model to begin with that helps people to make solutions and decisions about their health, and then lay out the AI on top of it instead of just putting in every known piece of literature about health and then expect it to be able to spit something out. And because my point during that was, we don't even know what happens when people take 3 drugs together at the same time. Right? I could name any 3 drugs that people were put on all the time, and I'd say, okay, give me the data on it, give me the trials. And for the most part, unless it's like maybe a cardiovascular trial, maybe a diabetes trial, you don't see 3 drugs at the same time. And if you do, like in a diabetes trial where they had the more aggressive the drug therapy, the more people had adverse events, it didn't turn out so good. That's that polypharmacy conundrum we're in. So when we start to combine, and this is where I think the promise of AI is at, right? What drugs are you on? What nutrients are on? How much caffeine do you take in? How are you sleeping? What is your wearable data? What's your exercise pattern? What is your life like? And what is that outcome looking like on telomeres and epigenetics and, the expression of what you're building, right? You're either building health or you're not. But we can't show people that real easy, right? Like,
well, we've talked about this. This is another AI thing. Instead of people putting on a CGM, your doctor of the future will just strap a chat GPT to you. And it's going to say, okay, well, let's, you don't feel good, you're tired. Let's see what a week of your life looks like.
right.
And, eating potato chips, getting 5 hours of sleep a night, scrolling on your phone all day. You spent 10 minutes outside. And then your doctor says, well, looks like you need to spend more time outside, get a little bit more sleep, stop eating the potato chips. And the patient's like, well, I could have told you that.
This
Right.
is kind of what
but
Andy's company, Absolute Rest, does. They send you a little box for your room. They measure the ambient temperature, the light, et
So
cetera.
some
Right.
applications, it's already happening.
Yeah.
Oh, absolutely. Well,
That's
Ultra
like
Humans doing that, right?
Yeah. I mean, that's basically, those are early models, just like we had early model computers decades ago. And now everybody has a smartphone computer. It's going to get much better very quickly.
And let's talk about the adherence to that. Does that mean that we're going to have like a cattle prod come out and hit you when you now that I'm
already
your
talked
doctor and
about
I've
it.
identified through ChatGPT that you're eating too many potato chips, when you go to reach for the potato chip, you get a shock.
From the
or you get a
CGM,
negative tone, like a womp, womp, womp,
We've
instead
discussed
of,
that,
yippee-i-o, right? I mean, that's the part that's, it's...
That's the age-old question is, in
Free will,
any
man.
in any business, how do you get people to do what you want them to do? Whether it's for their health, working for a company, that's sort of just trying to organize things and make them more efficient.
And that's the old medicine versus the new medicine. Like, you guys are obviously looking at you. You're committed to health. You're healthcare providers. I'd say for me early on, people, when I was talking about this stuff in the 80s, I remember I walked into my partner. So my partner, he was the head of General Electric Medical. He was my internal medicine doc in our institute. And then I had General Electric's chief technical officer and board member for Procter & Gamble. and then had the top guy and maybe wrote 14 textbooks on MRI and imaging. So I was the fourth partner, and the fifth partner was Chris Collinsworth. We had a thing called ProScan Imaging and the Lavalle Metabolic Institute. The first day I walked in the 80s, internal medicine guy looks at me and says, "So what do? Cut chicken heads off and swirl them?" Because for him, it was all about it, right? It was, oh, you're voodoo, right? In the 80s, it was, oh, you're voodoo because there's reactive medicine, right? And there's still a lot of people that just want reactive medicine.
Yeah.
They don't care about lifestyle, and we can't judge them for that. And we can lead them to the water. We can't make them drink. We all are jaded by the fact that we're passionate about health.
Yeah.
And I happen to think we're on the right side of the future, right? But it's that fuzzy transition in between that's difficult, right?
That's what's difficult with our organic machine human bodies is if you're a car enthusiast, then it's completely reasonable if you don't want to soup up your car and keep it looking good and performing good. And if I was a car enthusiast with my body, then I would be the biggest car enthusiast. I would want it to be a classic car, still be able to race at some point within reason. But a car, you can just buy a new one. You can't do that with a human body.
That's
so
right.
it's difficult to say, well, where do you draw the line? What is your personal responsibility for this?
Right.
Because otherwise it is a drag on the system.
Well, I mean, obviously, look at our healthcare costs, right? I mean, our healthcare costs are incredible, and our quality of life in terms of industrialized nations ranks pathetically low. Our obesity rate is incredibly high, and then that intersects the issue of how much chemicalization of our food, how much sugar's in our food, how much we've allowed for sugar-laden drinks in our food. I mean, if you saw there was just a study that came out. I mean, it was just a couple days ago on just pointing right at soft drinks as being like the biggest cause of obesity again. Then like we just learned it, right? And I think, look, we've got things that need to be changed on a drastic level here. Like there's so many things that are off.
I think that was our worst received podcast when James mostly jokingly proposed a tax on sugar sweetened beverages.
Yeah, I just said something reasonable like orange soda should cost $50 instead of 99 cents. And people lost their minds.
Why?
I mean, if you want to
Would you do that to orange juice too, since it's pretty high in sugar, or is it just like the sodas? It's a fizzy orange, or could it be all orange?
Yeah, I guess if you don't carbonate the orange juice. No, the orange juice is interesting because it has some other things it's packaged with. So you can't just say, oh, if it has some sugar content. So there's some nuance. There's always going to be some nuance.
You know what I learned about orange juice, though? I was doing blood sugar sticks on people in Kroger's. In 1983, I decided I was going to tag foods. And we were going to do wow events, test blood sugars, test lipids, and I tagged the whole store with heart-healthy, diabetes-friendly big tags because we didn't have digitalization then, right? So you have to go around and manually tag a big sign on 500 foods and then create this wow event. So I'd make kids run and drink the orange juice that people were putting out as here's our healthy world. And then they always wanted to get their finger stuck because they love bleeding. And they come back, they get their fingers stuck, and their blood sugar is like 260 after drinking a nice shot of orange juice, right? So I always, I'm not a big, that's where it gets, I would probably want, so I'm going to follow you up. If you buy full strength orange juice, it's $50. If you buy it diluted by 75%, it's only $3.99. Right?
You make the reasonable choice, the obvious choice. Like the healthy choice has to be the cheapest. And, with technology, I mean, the best tasting. If you make that the option where the healthiest thing is the cheapest and the best tasting, people are just going to go that direction.
Yeah, we could 3D print our flavors.
Right now, we just have it the opposite. Yeah.
Yeah. Naturally best tasting, perhaps.
Yeah. I'm a huge Whole Foods and natural advocate. So, totally line up with you on it. I think we've got a big task in front of us. So, because I also, who do you listen to if you're the government right now? Say you're with RFK and the movement of health, which is very cool, by the way. I mean, my God, we're finally focusing on Americans' health. Wow. How many very sick people do we have to see, right? But who does he listen to, and what shapes that policy?
Hopefully, the Gillett Health podcast.
Yeah.
I'm with you on that.
Yeah.
I mean, you guys are common. All kidding aside, you guys are common sense and hitting things responsibly. But a lot of what I've seen is a little bit different, and so there's a little. I mean, I at least have privately have a little bit of pause for concern.
Agreed. We talked about this in our last podcast. There's big pharma and there's also big functional, and it's a good thing that we have companies that are making money and making good products, obviously, both from the pharmaceutical and I suppose functional standpoint.
Right.
But people are somehow very concerned about the big pharma lobby, but maybe not concerned about these huge functional medicine clinics and companies and this and that. They have a lot of power. I mean, I follow some of them, and a lot of them put out good information on a lot of things.
Yeah,
but
of course.
They have come into a lot of power now. That being said, the pendulum's probably been swung one way for a long time, I think.
Right.
And now perhaps it's swinging the other way, which might not be bad. And hopefully there's going to be an evening out of those two things. But we really don't know.
Yeah, I think it becomes simpler when we all think of, we're a team to help people get well. So, at least when I've built my institutes over the years, I valued the dietitian, I valued the medical doc, I valued the professional strength trainer that was there. I valued our acupuncturist. We have to think more about the person than I'm right. Because I think that happens a lot.
Yep.
And I think that big pharma clearly needs to embrace lifestyle more because they don't. In general, quote, functional, and I think of functional as one term in the space: regenerative, anti-aging, longevity medicine, precision medicine. Functional for me somewhat limits it because it's really focused on food and diet for the most part, and maybe taking nutrients, and that's it. So I think that there needs to be the responsibility, because what also happens on that pendulum swinging back is all drugs are bad. And we all know that's not the case, right? Drugs save lives. They do save lives every day, especially the more you're not willing to be compliant.
Yeah.
The more you don't want to change your lifestyle, the more important a drug is, right? I don't want to lose the 20 pounds. Does that mean we say, oh, well, we don't have anything for you. You're just going to die of hypertension, and your blood sugars are going to go high, and you'll get renal failure? No, their medication is there, and we're hoping that we now can instill the need for less meds, because I'm a huge advocate that people are on too many meds, and polypharmacy is probably the biggest risk out there of what people are taking. Too many meds, and I don't think taking more supplements is like in that danger category. I do think it creates complexity when you start to add like 15 dietary supplements and 8 medications and 6 peptides, and that's when you asked me earlier, what's too much? It's when we just start to create this soup and we don't have any mechanism of tracking the person. What are you tracking to show that it's improving what you're doing? And I'm always thinking, what can I get rid of next? What's the next thing I can get rid of? What's an essential thing they need to be on? What's the next thing that they don't need to take anymore? Let's make it affordable for them, because not everybody, that's the other thing, is this has been a little bit of a class issue where unless you have money or you were sick enough and you got so sick and you weren't getting answers in conventional medicine, then you're like, oh, okay, I got to find money to go this other route. Or, hey, I'm into prevention, I'm into longevity, and I have the money to do it. So now but as we adopt more and more of this, supplements aren't cheap when they're made well, right? Standardized extracts are expensive when you buy them in bulk, especially if they're the ones that were used in the studies and they're pesticide-free. And, they're done in a clinical dose when the consumer buys them, because that's the other issue. People buy stuff, there's sprinkles of stuff in them. There's no clinical data or on the doses that are given at all. And I think there's just so much complexity in this whole thing.
Yeah. Really appreciate you being able to see kind of both sides of this with your background as a pharmacist and a naturopath. And part of it becomes, like you alluded to, like harm reduction. If someone isn't making changes and you see them on this trajectory, doing nothing is something that's an option, but it's probably not going to be the best option. It becomes harm reduction.
Right.
So I guess you sort of alluded to the differences in, the functional medicine versus the traditional medicine. Is there anything like that, I guess, historically or even today where, like, between naturopathy and pharmacist, or are you seeing those things come more together? Just thinking like the last decade or so.
Yeah. So, I started at naturopath school in Ohio. Never really got to where I gave an academic degree, but never really got it to be able to be licensed. We just couldn't get it over the goal line in Ohio with the state board. But I've been around. A lot of my mentors were naturopaths. I think there's a blending now that naturopaths are writing scripts, right? So naturopaths before would only be like, botanicals and nutrients and, those kind of things. But now that they're writing prescriptions, I think there's that blending that's starting to occur between, thinking about herbs and thinking about drugs. It's a long way away. For the average pharmacist, it's a long way away. And I think we don't take advantage of, if people understood how pharmacists were trained, we would have a lot more pharmacists and there's a portion of them that are getting trained in our kind of like integrative, regenerative, functional field, whatever you want to call it, right? But it's so few and far between. And when they realize we have to learn every drug of every specialist, any doc that's a specialist works on about 8 drugs. We got to learn every specialist, the physiology, the pathophysiology, the medication on all of them. We got to know all that stuff. And then if you layer in your ability to know knowledge of natural compounds on top of it, it becomes pretty powerful. And I think they could be great allies to a physician, not taking the place of a physician. I'm not a medical doc. Taught at medical school, but I'm not a medical doc. I'm not a DO. So I've always had physicians in my practice with me because I really respect what they do. I could have chose to go just sit back and go, hey, I'm going to give some herbs and give some nutrients and do some lifestyle, do some coaching. I think there's that need for, what I call, interdisciplinary care.
Yeah, that's why we call our clinic a academic center with an interdisciplinary team without the red tape, because the red tape
awesome
hurts quite a bit.
Yeah, depending on who you take healthcare dollars from, then they may say, hey, no, you can't do anything that's not FDA-approved. Peptides, are a no-go.
Right,
so,
right.
So you sort of have the best of both. And we call individualized medicine because we take the patient values, their resources, because everybody's in a different spot, take evidence-based things from both traditional and functional medicine, sort of put it all together in a plan that someone is reasonable, right? Because you've seen some of these protocols where it's like nobody could do that. You can't stick to that kind of thing.
Right.
You just set people up for failure, and we want to do the opposite of that.
And I'm curious on your advice on this too, but we meet at least once a week as a team, our dietitians, our healthcare providers. We used to have a pharmacist. My sister-in-law is a compounding pharmacist that's worked for several that are big in the functional medicine sphere. But
awesome.
We frequently ask questions to each other and bring cases. It's continuing education, really. But one thing that is always going to be difficult is finding where to get this. You're trying to apply a cutting-edge therapy, but you're trying not for it to be bleeding edge. And how do you discern those things of what and when, other than reading your books and listening to CME?
Yeah, well, safely on the leading edge, right? It's like I'm going to get to the edge of the Grand Canyon, but I'm not going to leap off. I think that's hard. I think it just takes common sense. I always ask around for the people that are already doing the, bleeding edge, and hey, what kind of side effects are you getting? What's happening? Are you really seeing improvement? I investigate, pretty strong. I'd say I'm always been someone who has taught Obviously, all my docs at the American Academy of Anti-Aging Medicine, International Peptide Society, as well as in conventional medical and in environments and university environments, is I'd say I'm safely on that leading edge because I'll give you a good example: stem cells. I'm not anti-stem cells. I'm not pro-stem cells, and I'll tell you why. I think it depends where they're at. I don't think we've got great standards on where they're at yet. And I've had cases of colleagues that have had them done on themselves, and adverse events have happened with them.
Yeah.
And so when people ask me about stem cells, I kind of can't give them hey, I feel pretty comfortable about methylene blue. I don't feel so comfortable about stem cells yet because I'm not schooled enough to understand for sure you're going to have a safe experience with it, because I've had people that are close to me that have not had safe experiences with it. And so it's not just, I think it's, once again, right now, everything we're doing, it's experiential, right? I mean, a lot of these things that are coming out, what happens when you do stem cells with PEMF and then land a red light bed? Because that's what people are doing. They're mixing all this stuff. Mm-hmm. And I applaud you guys for, first of all, having meetings and going over case studies, because for me, that's how all the staff learns together.
Yeah.
And you also see the value of all your staff and their wisdom when you do that. But in the end, you come to a consensus that way and everybody feels good about it, right? Which is great. When you figure out how to, have that sieve that pours in the new, therapy that makes it through the sieve, without look at the papers, but the main thing I do is I ask around, because I've seen so many therapies that got started in this space, and oh boy, I'm glad I didn't do that, right? Either because of lack of efficacy or adverse event relationships.
Mm-hmm. That reminds me of, I forget the peptide, but there was one that, patients are asking me, hey, what do you think about this for immune system benefits? And I'm like, none of our pharmacies we work with carry it. And then I'm like, let me just see what some of the papers are saying. And it's like, yeah, it plays a role in the immune system. But then you also see these studies that link it to heart disease or link it to the inflammation in the brain and dementia. I'm like, hey, I'm not going to prescribe this. And, if you plan on getting it somewhere else, please do not, because the data is kind of a mess, and we don't really know. So when there's people who are, I guess, the cowboys, right? AFRM, they may talk about some things that they're doing that are, they don't have the published literature. They haven't done a phase 3 trial of it. It's not
Correct.
FDA approved. But, they're going to say, hey, these are the good things we're seeing. These are the bad things that we're seeing, or this is how we've changed it. And like you said, the more things you try and layer on top, you may have more questions than answers.
That's why I love people like Brian Johnson, the Blueprint Brian Johnson, not the Liver King Brian Johnson. Not that I don't like that one either, but he publicly talks about what goes well and doesn't go well. He'll say why he didn't like his rapamycin, even though he probably wasn't checking the level that it peaked and troughed at. But I do like that. I do like that he publicly says all this thing. It helps further the people who are interested in that.
I mean, he's sacrificing his body for the good of a lot of people. I mean, that's my opinion of what's going on. He's pumping a lot of stuff in there. And I agree with you. I think that's good to be honest about it. How am I feeling? What was great? What wasn't? Did I age by doing that? A lot of times when you do those senolytic agents, you get a increase in biological age for a short period of time, and then you get the refractory swing back to an improved biological age. But I mean, yeah, I think it's a very slippery slope when all we do is reach for, I just need one more thing and I'm going to be healthy. I'm going to live. Like everybody wants to live to 120. I just want to get people to 85 healthy right now. I mean, that's my first goal. Can I get people to 85 healthy without needing a bunch of meds? And they're vibrant, resilient human beings. I would love people to reach escape velocity, right? The term.
Yeah. Escape
velocity. And wow, it'd be awesome to be 120. My dad lived to 91. I mean, it was great to see. He was diabetic. He had renal failure. He had a duodenal adenocarcinoma, had a Whipple at age 79. But he lived to 91 because he came to live with us at 91. Got to see his grandson grow up in the same household as him, changed his diet, made him get on a treadmill.
Yeah.
I was like, you're going to live in my house, you have to get on the treadmill. He's just coming out of Whipple surgery. He's 88 years old, right? But he lived to 91. So the other thing I think is the sign of hope is for the people when we're talking about how confusing this can be and what's the genesis of all this change. I really believe that if we can just get people to begin the path, he felt so much better and lived a lot longer than what his expected life expectancy would have been as a 79-year-old diabetic with renal disease having a Whipple surgery. Mm-hmm. Typically, 2 years.
Yeah.
Right? He lives 13. So I think, a lot of cutting edge stuff that's cool. Yeah, I think the Brian Johnsons of the world, it's interesting. It's also, I'm going to give you the flip on that. Do you think there's anybody that's saying, well, I could never afford that, so why should I worry about longevity?
I'm sure there's somebody. There's some people that are seeing this and they sort of, right? Some people would look at that with disgust. They're struggling day to day and they think, well, this person's, wasting $2 million a year on their health and, I can't feed my family, things like that. So it can create, like you mentioned, a class sort of thing where there's a divide there. And, you hear people talk about, the food deserts. And I think you have to there has to be some mental work there, either on an individual level or a society level to say, hey, there still are, affordable ways to eat healthy. We did an episode where I was like, what is just the cheapest you can get? Sufficient protein, sufficient
Whole
fiber.
Foods.
What's the cheapest, fruits and vegetables, get your polyphenol content.
That should have been a dramatic episode that changed the consciousness of people. What happened here?
Yeah, sometimes those don't do as well. Sometimes people are more interested in whether or not you're going to do hyperbaric oxygen in the next 5 or 10 years.
Yeah.
Which is also an interesting question, but it's not as applicable to, food and diet is applicable to everyone, and everyone can improve their diet, and that's almost always the highest return on investment if you're investing a certain amount into your health, whether it's $100 or whether it's $1,000 per year, whatever it is.
What kind of diet could that $4,000 you spent on a cold plunge get you over a year? That would elevate your diet so much more than anything that cold plunge could do for you.
You know what? You just said a comment that's you're gonna be very unpopular again, like the $50 tax on
there
the
goes our
soda pop.
sponsorship.
I'm just telling you right now. I mean, I could not agree with you guys more on that. No, look, I think we need those explorers, like Brian Johnson. We need explorers. That's how it's how we found insulin. People exploring, right, in science. So it's all good. But I am a big advocate of so we talk about government and make America healthy again. How about our government programs for providing food isn't just for bread and cheese? I worked inner city farm. When I first got out of school, I was in an inner city pharmacy. I worked tough neighborhoods because I was 256 pounds of muscle. Nobody's going to rob this kid. So we're going to put him in the roughest neighborhood in the greater Cincinnati area. And so I had a lot of people that were on Medicaid cards, Medicare cards, using food stamps. And, why don't we allow people to buy healthier foods too? Because that also prohibits it. So that's why I've got a lot of hope for what we're doing. If we can just start to change that kind of stuff around, it's going to be big. Because I could not agree with you more what you just said. It all starts with food. So one thing we have to do, we have to drink water, we have to eat food. I mean, after that, we don't need to take ginkgo. We don't need to take a statin.
So what should we fund? Should we fund carnivore diet and tallow?
Man, you just go
soybean oil, but only high omega-3 soybean oil.
Right at it.
Yeah, I mean, people always ask for actionable items and whatnot.
No, okay. So I'll give you my take on diet. I mean, and I'm not going to say, oh my gosh, I'm the only answer to this. So, I've had dietitians in my practices for close to the 40 years that I've been doing this work. And my wife's a dietitian. She's probably one of the smartest dietitians I know, and I'm not saying that because she's my spouse. She's been around this game a long time, knows the literature, very smart. I think in general, if you look at high-fat diets lead to endotoxemia. You get more circulating lipopolysaccharide. It's been published over and over again that you make more lipopolysaccharide that break down in the microbiome, and then the release of circulating endotoxin when you eat a strictly high-fat diet. So
is that more than 50% of calories from fat, or is that more than 150 grams a day? Or?
I think it's more like, is it void of eating vegetables? Are you void of having fiber? Are you getting resistant starch? As you know, you don't get a ton of resistant starch in a carnivore diet. You eat a ketogenic diet, you don't get a ton of resistant starch. And I think, so short-term gain, typically awesome, right? Because you're no longer relying on the insulin receptor too much, right? So you get that short-term burst of, wow, my brain is so much clearer. I can't believe how much better I'm thinking by no longer eating a half a loaf of bread in one sitting, right? And now I'm eating protein. I'm still making energy from that protein, but it's slower. I'm slowing down that insulin receptor activation that typically is already abnormal, which is creating a lot of, inflammatory chemistry because of it. And so there's that short term, hey, you want to go ketogenic, you want to go carnivore, you want to kind of clean things up, fine, short term. But long term, I think that becomes a problem. I think there is specificity to foods, meaning that the more people have gut permeability, the more they could have food sensitivity, not allergy. Allergy's pretty straightforward. I get hives, I get itches, my airway's closing. Probably pretty alert. You can figure that one out pretty quick, right? But I do believe sensitivity is an issue. It's why people go to Europe and they eat food that's not hybridized and doesn't have a bunch of stuff, added to it. And they don't have as much water retention. They lose weight and they feel good on the food. So there's something to that we've got an immunologic issue around the foods that we're eating here, specifically in this country. And then I think that there's genetic differences in how much carbohydrate people can tolerate. There's some people that can tolerate more carbohydrates. Some people tolerate less. What we've always done with our approach to diet is we start people off with modified low carb, not low carb, modified low carb. So you're going to get 75 to 100 grams total carb, including vegetables. We're big believers in vegetables. And we just use a simple rule for people: 3 vegetables to every fruit, and pick low glycemic fruits, right?
Yeah.
Simple rules, simple things.
That's good.
And then, protein, I mean, it depends on who you're going to listen to. If you're going to listen to Walter Longa, people are eating way too much protein, but until you hit your 60s when you need to increase your protein, right? I think that people probably need more protein than that, but then I do believe that there's some people, like in the carnivore diet, where they're overdoing protein. If you're not measuring the pH of your urine, which people should be doing, there's a reason why we give people sodium bicarb capsules right before they go into total renal failure. Because when we alkalinize their urine, it spares the little bit left of the nephrons, the kind of the sputtering of the renal function that's left is spared by alkalinizing. Well, what's an easier way to alkalinize? Eat vegetables, have adequate magnesium on board, have adequate potassium on board.
Yep.
And I also don't think that, on diet, so we take people through a 3-phase approach to teaching them how to eat. I don't believe in a diet. I believe in eating for a healthy life. So eat whole foods. We may have to take some away to see how you do and to break your insulin resistance to start. Let's start to add them back and see how you do. And then what's your level of activity like at maintenance? Are you going to, go work out 3 days a week for 30 minutes? Are you going to walk 30 minutes 5 days a week? Are you going to go do, hardcore training? I don't know. Everybody's different on how much they would love to exercise. I love to exercise. So everybody's different. So what is your need for calories, and what does that look like in terms of how you're making your daily selections? And that's kind of how we try to approach diet. And that would be eat more whole foods. And, it's this whole thing of gluten. Yeah, gluten's more about hybridized grains. I mean, people go to Europe, they eat, we sell them all our grain. You know, all the best grain that the Italians buy comes from Arizona, right? You guys knew that, right? We grow all that and ship the good stuff to another country.
No,
Yeah, it's kind of crazy.
didn't know.
So that's kind of the thought on. You know, for me, diet is more about. I don't give a crap whether you're 35% carb, 30% carb. No, 37.5% carb. You know, 41.3% protein. That isn't the issue. It's understanding how to fuel your body so that you feel good and you have your. Look, you do have to try to keep your body weight down. We know that there are issues around having higher percentages of body fat. So how do we get people there? That's my diet.
Yeah, we certainly concur, both with the statement that carnivore and ketogenic diets are usually temporary, and also that whole food diets are good, and the best diet's one that you can learn to adhere to that lasts a lifetime.
That's right.
Regarding fiber, do you give people a daily minimum goal? You mentioned the various types that are important, and
Sure.
And obviously you want to make sure you're getting multiple types of fiber. But do you tell people, 30 grams for females, 40 grams for males, 50 grams for both?
I tell people get a minimum of 30 in. Just get a minimum of 30. If you can get more than 30, like in the 40s, I think it's awesome once you build up to it. Most people can't tolerate that right away. A lot of times it'll shut them down, get them constipated. So I'm a huge fan of fiber targets, especially if you have people on bioidentical hormones, right? When they're on bioidentical hormones, fiber helps them on the processing of those hormones, reducing that beta-glucuronidase enzyme that's occurring because of unfriendly flora and cleaving off, right, the glucuronidase that's on that hormone. You're going to cut that off and let them circulate again, right? So I'm a big I really believe in that. Just anything over 30, and I'm a fan. Do you have to be 50? Once again, if I can get people, it's that same old thing. If I can get people to live to 85, I'm going to be pretty happy. I know the goal's 120. If I can get people to get 50, and I'm pretty, that would be a great goal. But if I can get them over 30, it's way more than they're currently getting, because people don't realize when I talk to them and say, well, it's 2 grams of fiber per serving of vegetable or fruit.
Mm-hmm.
How many of them are going to go, okay, that's 15 servings of vegetable and fruit a day, unless you add legumes, right? You can add legumes at 8 grams, 8 servings, 8 grams per serving. But the issue then is, hey, I'm gassy, I can't do beans. So then I'm typically recommending they add fiber to their diet.
Mm-hmm.
I'm a big fan of, sun fiber, of, Gorgum sun fiber, because it's easy. I don't have people have adverse or harsh events to it. They don't get knotted up. They don't get gassy. It can go in their water. It can go in their coffee. It can go in their energy drink, whatever they want to put it in. Mm-hmm. It dissolves and you don't taste it. So,
if you made it this far, thank you for listening to the first part of our conversation with Dr. Jim Lavalle, one of our favorite guests to have on the podcast and just a generally fun person to talk to. Be sure to stay tuned for part 2 of the podcast and leave any comments you have in the description below.